I want to thank you and let's see. Thanks, Jay. I want to thank you and USC for inviting me again to do something kind of along the same lines of what we did last time. Today, we're going to do CLI cases. And what I thought I would do is rather than show you tons of cases where it's too fast, very rapid fire, is I'm going to show basically an iliac case, an SFA case, and a tibial or below knee case. I figured that would give enough time to kind of go through it slowly, and then also if people had questions after each case, we could try to address those. So without further ado, there's my Twitter, there's my YouTube channel. Please subscribe or at least check it out when you have time. I have a lot of this stuff posted there. My disclosures, nothing pertinent. So the first case is a 54-year-old man referred for severe work and lifestyle limiting calf claudication, left leg worse than right at about 50 feet. He said that it started about 4 years ago with progressive worsening over the past few years, but most recently over the past 6 months. He has the classic risk factors, hypertension, diabetes. He's a smoker. Even though he quit 6 months ago, 15 years of smoking, you can imagine, will affect your blood vessels pretty significantly. And he's on a statin. He's got his blood pressure controlled, and he's taking a medication for his diabetes. His labs were within normal limits. And this is what he had on exam. So you can see that on the left side, he has a weakly palpable common femoral artery pulse, and the popliteal artery pulse was Doppler, and his pedal pulses were Doppler. So I think, again, if you do a good vascular exam, which is very focused, along with the history that most of these patients will provide and what you'll obtain by asking a lot of questions, you'll be able to really figure out the level of the disease. In this case, I knew that the right side was strong, was normal in terms of a palpable pulse. The left side was weak, so I was suspecting already that there's some level of inflow disease. And I knew, and then below that, we may have disease, we may not. It just depends. But in this case, I knew I had that. So you have to think to yourself, well, what's the next step in my workup? I did my history, I did my vascular exam. For most CLI operators, the next step in this case would be an ultrasound and non-invasive testing. So in our institution, we do basically PVRs with an ABI. Obviously, if you have a diabetic or somebody that's has chronic kidney disease, you want to do a TBI, because remember that is more accurate of a value compared to ABI. ABI can be very inaccurate in patients with diabetes and CKD, mainly because of medial calcinosis and the artificial elevation of the ABI that you can get when you have somebody that has diabetes, CKD. So in this case, this patient you can see has, and this is really another whole talk, which I can give at some point, but basically you can see that the left thigh waveform is dampened, and then everything is dampened below that, and then there's some dampening here, the transmet, and so forth, and the ABI is 0.6, 0.68. And, at the time, we also, now just based on this, I'm suspecting inflow disease on the left side, right? Because this waveform at the left thigh, if they had a normal distal aorta, left common iliac, and external iliac artery vessels, then I would expect that waveform would be more normal in appearance. And you can always do, you can always correlate this with your physical exam as well as a duplex ultrasound, right? So in this case, once I saw this, we actually obtained a arterial ultrasound, and you can see there was basically reversal of flow in the left external iliac artery. The left common femoral artery had a more, antegrade flow, although it's not 100% normal. And so these two things together, along with my physical exam, tell me that, well, there is inflow disease. And so some people ask, well, what do you do next? Well, in this case, I went straight to CTA because I wanted to see what I'm dealing with. I know that I have inflow disease. Am I dealing with an occluded aorta? Probably not, because the right common femoral artery was normal. Am I dealing with focal short segment disease, a long chronic total occlusion? What am I really dealing with? Is the inguinal ligament, is the artery at the level of the inguinal ligament intact? What's the common femoral artery look like? These are all things that will help me determine whether I'm going to basically do an endovascular fix or whether this patient's going to need some type of combination or hybrid fix, right? As in, do they have severe disease in the common femoral artery? Well, then in that case, this patient may need an endarterectomy with a patch. So in this case, you can see that that basically I had a flush occlusion of the left common iliac artery with some level of reconstitution at the inguinal ligament. If you remember, you know, the angiographic marker for the inguinal ligament is really the deep circumflex iliac and the inferior epigastric. So we know that's the angiographic marker also for the junction between the left external iliac artery and the left common femoral artery. And so although I'm showing you this over here, and I'll show you this in a little bit slower, what I'm looking at is where's the level of occlusion and where's the level of reconstitution, and what do the proximal and distal caps of this occlusion look like, because that'll help me determine my approach. And I also want to know what the aorta looks like. Is there an aneurysm? Is there a dissection? Is there intimal? Is there a high-grade stricture? That's all going to change your approach and kind of how you deal with this. This is actually a pretty complicated iliac case, if you ask me, because there's also disease in the distal aorta. And like most chronic total occlusions, when you have long segments, especially with inflow, you can see the rest of the leg looks pretty decent. I mean, obviously they got some tibial disease, but overall, look at that SFA and pop wide open on the left side. And that's the side that was where he's claudicating at 50 feet. That's worse than the right leg. Right leg, he's got a pop occlusion, but you know, there's no need to address it at this point because right now he's saying this, the left side is what's bothering him the most. And it would make sense, right? Because the left side is worse. So when he walks, that's what hurts first. So he doesn't walk far enough for the right leg to bother him. And that's probably something that'll bother him after you fix him. So the way I look at this aorta, if you look at it, is basically, I know that there's a flush occlusion at the level of the left common iliac artery. There's reconstitution here at the level of the junction between the external and the common femoral artery. So here's that inguinal ligament we're talking about. So these are very important collaterals. If I'm going to put in covered stents or treat this, I need to make sure that I don't cover these very important collaterals, because when this disease goes down, this is what opens up. This is where you get your collaterals. And so that's something I look at. The other thing I look at is the status of the common femoral artery. Is it normal? Is it abnormal? I actually knew by ultrasound that it was a relatively normal vessel without significant plaque. There was no significant narrowing. I knew that the deep femoral artery was also widely patent. And so I knew that I at least had a good landing zone here, in the sense that I would be able to stent down to here without covering this. The other thing that I noticed is that you can see there's some narrowing in the distal abdominal aorta, and you can see there's a lot of atherosclerotic plaque or soft plaque. This is not thrombus, right? It's better to call it soft atherosclerotic plaque. And you can see that the aorta is narrowed as well. And so if you see this here, here's the distal aorta as we're basically coming down on CT. Here's the right common iliac artery in that middle image. Here's the left common iliac artery origin. You can see maybe there's a nub, maybe not, but there's clearly a flush occlusion. Here it is here, occluded again. And if you notice, look at the size of the left common iliac artery. It measures about 10 millimeters. Look at the size of the left external, 7 millimeters. So on CT, it gave me a lot of good information. Showed me what where the occlusion is, how long it is. I'm able to measure the vessels and get a size so that I know that if I am successful at crossing this occlusion, I can basically determine from the CTA alone what size stents I need, what size balloons, what I'm going to treat, what my approach, and so forth. So the way I'm going to approach this is basically looking at all this is I knew that I would have a size discrepancy. If you look at that top right image, the distal aorta measures 22 to 24 millimeters. I know that the common iliac artery measures 10, and I know the external measures 7. There's a size discrepancy there. And, you know, we can have a long discussion of whether you use, uncovered stents or covered stents. But I think in general, most people would say from the data that, you know, most people would use balloon expandable stents in the common iliac arteries and self-expanding stents in the external. If you think of the external kind of dives down into the pelvis before it comes up to basically transition into the common femoral artery. And so by putting in balloon expandable stents in that area, there's always a risk of rupture. And that's what you worry about with any external iliac artery. And so my kind of thought process when I look at this is, okay, what kinds, I know the sizes now. I know the size of the distal aorta, because remember, if your distal aorta measures 20 millimeters, you're not going to put in 14 millimeter stents kissing on both sides, because that may be too big for that distal abdominal aorta. So that's the reason you want to know the size of the aorta. And there's a good article I'll have to share with you next time, that tells you that based on the size of the distal abdominal aorta, what's the size of the kissing stents you could put in that it'll accommodate. So that's a very important thing to think about. So for me, the way I think about this, well, I know I'm going to have to stent once I cross because balloon angioplasty is not going to keep this open. I do have some level of calcification here. And so for me, I'm thinking, okay, am I going to do uncovered or covered? In our lab for iliacs, we use covered stents because that, you know, we worry less than about rupture and so forth, and we feel like it's a little bit safer for us to do in our lab, and so that's why we do it. But there's many of operators that use basically uncovered stents, so you can do that too. So for the common iliac arteries, my plan is I'm going to basically go right groin up and over so that I can do diagnostic angiography from there. I'm going to basically get access on the left side retrograde, and I'm going to try my recant from there and see how far I can get. And the reason I'm saying that is because I have a flush occlusion here. And so trying to figure out where this origin is going to be very difficult. So I thought, let me start here and head this way first and then see where I end up. The other thing in terms of my plan is I'm going to basically use covered balloon expandable stents in the in the common iliac artery, and I'm going to use a self-expanding covered stent in the external. And so I thought that would give me the best of both worlds. But the one thing you also all have to realize is that once I cross this, I can't put the bigger stent in first and then the smaller one, because otherwise you'll have a mismatch here. You have to put in the smaller one first and let the bigger stent telescope into it so that you have no mismatch and you have no endoleak. So now looking at this, you can say to yourself, and I talked about this a little bit, always assess your caps. Here's the cap on the my distal cap, and then here's my proximal cap somewhere around there, which I can't tell. And so just based on cap morphology, I knew that this one has more of a favorable shape like this, that if I'm coming from this side, that at least I'll start intraluminal at the beginning, and then that'll give me hopefully my best chance to cross. So on angiography, you can see I got right-sided access. I did a pigtail run. You can see that there's a large inferior mesenteric artery. So when I place my stents, I have to be very careful about not covering that, because that's obviously a major collateral. I wanted to see the status of the common femoral artery and where the inguinal ligament is here. You can see I don't see it here on this AP view. So then what do? I do an oblique, right? So in this case, I did an oblique view. And you can see down here that you're getting filling of the common femoral artery down here. But you'll say to yourself, wow, that doesn't look that great. The good thing is I had a CTA. I had already looked with ultrasound when the patient was on the table. And so I knew the common femoral artery and even the proximal SFA and the deep femoral artery looked pretty normal and were wide open. So I punctured as low as I could in this case. And you can see my access site was common femoral artery on that far left. You can see the catheter, entering right here. Here's that cap I was talking about with a relatively favorable morphology. I want you to watch this here. So I'm using a CXI, a Cook CXI CTO catheter. It's an 018 catheter. I have a CTO wire. We talked about tip load in the past. Tip load meaning how many grams of pressure to deflect that distal 1 centimeter of the wire 2 millimeters, right? So in this case, I'm using an Abbott 250T guide wire. And you can see basically that I am recanalizing with the catheter and the wire, and I basically reached my pigtail, which is at the bifurcation. And so at this point I thought, wow, look at this. This is great. I'm almost done. It took less than like 2 minutes, right? So what did I do? And this is one thing I want to teach everybody. You have to do orthogonal projections, whether it's with angiography or whether it's with CTA. And so what I decided to do is I did a cone beam CT, and the cone beam CT showed me that I had already exited the artery here, and my catheter, which looks like it's ready to get into the aorta or is in the aorta, is actually somewhere in the periaortic tissues. And so this was very eye-opening. So I knew that I had to at least pull back to here. So I think when you do iliacs, you know, in our IR suites, we're lucky. We have cone beam CT. We use it in liver therapies and other stuff. So I think a quick spin without contrast will give you a lot of information. It did here. So I pulled the catheter back. down to here, and then basically use the imaging from the cone beam CT to help me redirect. And I knew which direction I had to go, whether it was anterior, superior, lateral, medial, and I was able to get to here. And once I got to this spot, I again did another cone beam CT, and you'll see this. Here's our catheter, and you can see that now I am within this vessel all the way, and you'll see it joining the right side, and I'm right at the crotch of the distal abdominal aorta. And you can see here on the reconstruction. So now I knew that, you know what, now I'm in a favorable place. And this really helped. And this is really what it looks like when you're recanting a CTO. It's similar to recanting a common bile duct or an occluded vein. And so a lot of the skills you use for other parts of the body or different areas really apply for arterial disease as well. And the feel is similar. So you can see that the CTO, the cone beam CT really helped me localize the where I was, and also made me avoid a disastrous thing of entering the aorta in the side or up higher or in a place that wasn't safe. Obviously, once I had crossed, I basically did several obliques, and you can see here's an oblique here, here's another oblique here, and basically what I'm looking at is to make sure that I am intraluminal. I knew that I had entered the abdominal, or I'd crossed this iliac artery in a very favorable location here based on the previous cone beam CT before I'd punctured that last part to get in, and a contrast injection with a catheter showed that I was intraluminal. So kind of basic techniques that you all know. The next thing I did is I said, well, let me confirm my CTA findings in terms of sizing, location of reconstitution, as well as length, because I need to now determine how I'm going to fix this, even though I had a plan in my head. So I basically did IBIS, and I did IBIS for two reasons. One, I wanted to confirm sizes of the vessels, right? Remember, IBIS is much more accurate at determining the size of a vessel than angiography, and CT is very good as well, which I already had. And so I did that to, one, confirm my distal aorta size, my common iliac artery size, and my external iliac artery size. But I also use the IBIS to do another thing. Remember, when you have chronic total occlusions, that channel can be either completely chronic with calcification and hard plaque, or it can be filled with debris, fibrous tissue, thrombus, etc. And so before I start ballooning and opening this up and sending stuff down the leg, I did IBIS to basically make sure that there was no soft clot or thrombus or anything that looked suspicious there. When I looked, it looked basically like some chronic stuff, very echogenic, right? Just what you would expect to see if you were looking at clot on ultrasound. And what I ended up doing actually in this case is I ran an aspiration catheter through it before I did anything. So I took a penumbra and I basically just ran it 2 passes through there, suck out any debris, any clot, anything that could go down the leg as a precaution in this case. Or you can use a suction thrombectomy catheter or whatever you have in your lab. So once I did all that, I felt very comfortable. So what's the next step? Well, obviously I need to deliver my devices, my balloons and whatever else, right? So in this case, I basically did a PreDilatation. I used a 5mm balloon. You don't need anything very large. Remember, a 6mm balloon it's like a 2mm channel, so you can use a 6 as well. I happen to use a 5mm balloon in this case because I knew that would be big enough to allow me to deliver my devices. And so I have, as you can see, I obviously, and I'm not going to go through sheath sizes and so forth, but I have 2 8 French sheaths that I put in. I put an 8 French sheath on this side, 8 French sheath on this side, and then basically did my PreDilatation. I know that I have to deliver my external iliac artery stent first because it's smaller. So I want the bigger stent to telescope into it to prevent an endoleak and have a nice seal between the 2 different stents, right? We talked about that. I did an angiogram to make sure I don't cover this huge deep circumflex iliac or this inferior epigastric. You can see the status of the common femoral artery, pretty normal looking. Looked normal on ultrasound as well, just a minimal plaque really. And then here's the distal part of a covered self-expanding stent. In this case, I'm using a Viabond because I thought that it would give me precise placement, and it was covered and self-expanding and it would do well. And I made sure that I didn't cover those collaterals. So a couple of different angiograms, and you can see in the middle, if you, for those, I'm sure all of you have used Viabon. If you haven't, that's basically what it looks like. It's kind of like a ripcord, and you can see it in that middle screen, how the Viabon's being deployed there, basically. And then once I did that, I ballooned it to 8 millimeters. And then next up was this. And you could say, okay, well, why am I doing kissing stents when the left side is the only one? Well, if you remember, that distal aorta was very diseased. And what I wanted to do is I wanted to basically raise the bifurcation in this case and make sure that I covered that soft atherosclerotic plaque. And so I did two things. IBIS helped me decide that as long as I come up to here, and this I used different landmarks and so forth, and stayed below this inferior mesenteric artery, that I would be in a relatively normal part of the aorta. I would basically cover all that soft atherosclerotic plaque, and I would prevent it from shooting down the right leg when I deploy the left stent. So that's the reason why I did kissing covered balloon expandable stents, and you can see this is standard technique that many of you already know. Then I did an angiogram after I deployed all of these to make sure that I didn't cover up these collaterals. And you can see on this side, there's our collaterals, so those look good. And then on this far, on the right-hand side, you can see that now I've reconstructed the distal abdominal aorta. I've opened up that left iliac system, and his collaterals here are intact, and I have good runoff here. I checked the runoff at the very end just to make sure that the SFA and the profunda looked pretty good, which you can see here actually on this oblique as well. And then obviously, what do? We took out the sheaths. In this case, you know, I gave him, I typically give a bolus of 5,000 units of heparin. You can do weight-based if you want. I try to maintain an ACT of around 250. And at the end of the procedure, I always check the ACT, and I tend to give protamine to normalize it, and then we pull the sheaths. You can either use per close, you can use manual compression. In this case, we held pressure because, you know, we had 8 French sheaths. We felt like we could get good hemostasis, and he did well. And you can see there's the pre, there's the post. And then, of course, we always do non-invasive imaging. So I kept him overnight just to make sure he was okay. These patients, typically when you reconstruct their iliac arteries that have been chronically closed for a long time, is they'll say, I have this left-sided pelvic pain or discomfort or back pain. And so, you know, that's always related to the stents that you've expanded. You kind of opened up these fibrosed and chronically closed arteries. And so basically, I like to keep them overnight, make sure they're doing okay. I check a CBC, make sure there's nothing obvious in terms of bleeding. And you can see here, here's the pre-dampened waveforms throughout the leg, ABI 0.6, 0.68. Then you can see the post, basically normalization of the waveforms, and ABI is up to 0.94. And he did well. And so on follow-up at 1 month, his claudication on the left leg was gone. He wasn't really complaining too much of right leg claudication, even though he had that popliteal artery occlusion, because he was obviously well collateralized. And now he's jogging, so he did well. So that's our first case, our iliac case. I don't know if anybody had questions, Jay?
Yeah, there's just one question. Do you ever use a recanalization device like the barred crosser to try and stay true lumen / intraluminal in cases like this?
Yeah, so you can use crossing devices, but remember, even the barred crosser, it doesn't keep you intraluminal. It basically goes whatever direction you're pushing it. And so that device, you know, any of these crossing devices will not keep you intraluminal, but you can use them as a recanalization device. I think what's probably the more commonly used is like a outback reentry device is probably more commonly used to achieve access when you are subintimal and trying to achieve intraluminal access. I think that's probably the more common one. But you can use a barred crosser if you're very well adept at it.